Good morning.
Yeah.
Patient named Kumari, 49 years old, female patient, hailing from Palapura, who's a tailor, came to the department with the chief complaint of pain and swelling in lower right back tooth region since 10 days. Patient had a restoration done on lower right
She had
back.
complained of pain and swelling on the gums related to one of the lower posterior tooth. Okay.
The patient had a restoration done on lower right back tooth 1 year back due to decay. She experienced pain for 2 months, which gradually increased and noticed swelling and pain since 10 days.
Can we see the clinical picture?
So this was a first of the initial visit.
So there was an indication of a periodontal abscess. Any other clinical picture from any other angle?
Yeah.
Yeah. So there was this after draining it. Show the previous one. So there was a pointing abscess. A pointing abscess, that's what it's called as. So there was a periodontal abscess, which has already extended to the soft tissue area, and it was pointing towards the external area. So that means there is considerable amount of bone loss already there. And since on the X-ray you can see a furcation involvement, so what we expect to see here is, for some reason, there is a furcation involvement that has happened on this tooth. That furcation involvement is presently having a collection of pus. So it becomes, and it's a periodontal abscess. It's a periodontal abscess which has got a draining point somewhere outside of the gingiva. So this is right now a sinus opening. It's a sinus opening. So there's a sinus opening from the furcation region. So how will you identify whether this particular thing, the abscess, is directed from the furcation area or from the periapical area? It could be an abscess that has got an origin from the periapical area. When you see the radiograph, you can see even the periapical area is having some radiolucency. Even the periodontal area or the furcation area is also having radiolucency. How will you identify whether this sinus opening is related to the periapical area or the periodontal or in interradicular area? How will you track it? GP con. You need to insert a GP con and push it to any area where you feel the resistance. So naturally, that sinus has to be an epithelialized sinus. It will be an epithelialized sinus, so that will definitely permit the movement of GP con. And GP con is naturally radiopaque. So that is going to go to the area where it is permitted to the maximum. That will be the area from where the source is. I don't think you've done it here. You've done it? That should have been done. Or even for today's, before you start off today's case, whatever your planning is, before that you can confirm it. So insert a GP cone and find out which is the area from where the pus or abscesses start forming. Or is it directed towards the periapex? If it is directed towards the periapex, then the bone loss will be still more. If it is directed only till the interradicular area or the furcation area, then you don't expect to have that much of a bone loss in related to it. It will be limited to the furcation area. So what I understand is you're planning for some kind of an immediate implant planning here. So these two makes a lot of difference. Considerable amount of bone loss in an area where you're going to place an implant makes implant more challenging. Whereas if it is only in the interradicular area or in the furcation area, that means you have a periapex which is quite favorable for your implant placement, or the intact bone is expected in that area. Furcation area has got good amount of a bone loss, but periapex and the sulcus, so the socket area will be having an intact bone throughout all the surfaces. All the four surfaces will have bone. All the four surfaces plus the apex will have bone. Whereas if that particular tooth is having a periapical infection, four surfaces may be favorable, but the fifth one, the apex, may not be favorable because you have got an inferior alveolar canal apical to it. There, it makes it difficult to plan an implant in that region. Understood. A periapical radiolucency plus an inferior alveolar canal next to it. So you won't have any control over the apical area. An immediate implant gets its primary stability from periapical region, not from the surrounding region. Understood. So here you had this one. Then you drained it. Yeah. What's next slide? Yeah. You've drained it, so that has collapsed. The pointed abscess region, the sinus opening is not visible here. So that is gone, and the swelling is also gone. That means you've established a very good drain there. Okay, then what happened? You went in for an RCT. So all the other teeth are present. So that is the panoramic radiograph. Went in for?
should undergo extraction patient to do it due to claims that nearby.
Okay, this particular tooth. Then, yeah, come to that single tooth area. Yeah, yeah, this is fine. Panoramic is fine. Panoramic, OPG, OPG. Yeah. There, if you trace inferior canal, it is seen closer to the inferior canal region. Periapical abscess is present, was present there, or at least during the time of this X-ray, it is present there. Then root has resolved a little bit. Seems to have resolved a little bit. And if you see the radiolucency pattern here, the periapical radiolucency is seen almost closer to the inferior canal you have marked. The area which you have marked, the coronal area, the roof of the inferior canal seems to be closer to the radiolucency region, not to the root tip. To the radiolucency, it seems to be very close. So that's one thing that you have to be very careful about when you're placing an immediate implant in that socket, into the distal root of the first molar. If you extract this tooth, if you happen to extract this tooth, considering all these factors, if you extract this tooth, what are the other options? FPD. So you've got an option of an FPD or implant to have a fixed replacement. So, but if you happen to find the mesial roots of this particular tooth intact, only the distal root has got a problem. So what if we go in for a hemisection? You go in for a hemisection, then you will have two mesial roots intact. You can make it a premolar. Then you'll have a space in between this particular premolar and the second molar region. So this first molar will become a third premolar. And then there will be a gap in between this particular tooth and the second molar. Naturally, there will be a mesial migration of the second molar and even a distal migration of this present premolar as well. Foot impaction between this 5 and 6. When I say 6, that is presently a premolar. So there will be foot impaction between the present 5 and the future 6. That is again because there will be distal migration of the premolar when there is no supporting portion of that, supporting complement of that 6 will be removed. So there will be distalization of that root as well. So there will be foot impaction. And that particular 7 is going to easily migrate. So if you're planning for a hemisection, then your plan should be connecting this portion of 6 to 7 with a pontic in the area where you have done hemisection. Right? A pontic in the area where you have done hemisection, then a support from the mesial portion of 6 and the wall of 7. Then you'll have to additionally take a support from the 7. Right? Or else if you extract this 2, then 5 and 7 has to be connected. Total absence of 6. What is your other plan? Yeah, we have come across few articles wherein they have done hemisection and placed implant in that region, and they've connected that particular tooth root area which has been hemisected and placed implant to the same tooth, the other fragment of the same tooth. So that means a mesial is going to be left behind with the crown and the root, and the distal portion has been hemisected and removed, and there you have placed an implant and you have connected the two fragments of the same tooth. Something like a person having an artificial limb. So it will be like an artificial leg and natural leg connected together with a single crown. And case report says it has got a very good prognosis, whatever those people have done. So we can give it a try. So your idea will be to hemisect the distal portion, place an immediate implant in that region. Okay, the other fragment of that tooth, that is the mesial portion, has to be kept out of occlusion, completely out of occlusion, not to disturb the socket, distal root socket. And then waiting for it to heal completely. Then going for the same protocol, considering this tooth is another premolar and connecting it. So this will be a tooth implant prosthesis, tooth connected to the implant. An implant is not considered to be a kind of an ideal candidate to be connected to the tooth. There are few conditions applied here. Naturally, we don't connect implant to the natural tooth. Reason is a natural tooth sinks around 28 micron into the socket. Implant can maximum sink 5 micron alone. So there will be a seesaw action, more like a fixed implant region and a movable tooth region connected together, which will naturally help in uprooting the implant area. So naturally, that kind of an attachment is not done. But there are certain conditions wherein the prime condition is it should not be a long span connection. In a crowbar principle, when the effort and the resistance are too separated too much away. So the principle which we are referring to was the crowbar principle. So when the effort and resistance are too far apart, then little bit of an effort is required for a resistance to be easily manipulatable. Means you don't need much of a force on the effort side to uproot the resistance side. So when a tooth connected to implant are staying wide apart, a small effort, a small bite on a tooth will make it sink around 28 microns into the socket. That will naturally will result in uprooting the implant out. Now, what does that mean? As you come closer, the effort and the resistance come closer, it will be difficult to uproot it. The natural crowbar, effort, resistance, and fulcrum principle. So when you have an implant to tooth connection closer and closer, the implant tooth will have more stability. As you move it apart, wider apart, then little bit of an effort will be sufficiently enough to uproot the resistance side. Much of force will be focused to the resistance side. So as it comes closer and closer in the crowbar principle, what happens is much of an effort also will not have much of an effort on the resistance side. So if you bite on it hard also, uprooting the implant chance will be less. So if you have an implant tooth contact closer to each other, for example, you have a molar connected to a nearby tooth mesial root. For example, if you have a F7 connected to the distal root of the first molar, that will be closer placement of the implant and the tooth. At the same time, if you are going to place a 7 to the mesial root of the first molar, it will be wide apart. The effect on the mesial side implant will be more felt when you place it in the mesial socket than placing it in the distal socket, which will be closer to 7. So if you want to make a tooth implant connected FPD, then make sure that you are not inserting too much of pressure to the implant side. So that means less of pressure will help the crowbar principle, or rather the lesser effort in one point, which will reflect as more effort on the resistance side. That balance should be maintained when you connect an implant to the tooth. So when you happen to have such a case, which has got a socket intact, you can place an immediate implant and you're going to connect it to a root very next to it, immediately next to it. Then the crowbar principle is not going to work here. So that part is taken care. That part alone is taken care. But in such cases, if you don't have a very good interradicular bone, which is supposed to be the inter-implant tooth bone in future, then trying this will be again dangerous. Second thing is, you need to have sufficient diameter for this socket area to separate it from the nearby tooth as well. Because 1.5 millimeter has to be kept away from the nearby tooth. So your implant selection should be of lesser diameter in this case, so that you'll have enough of bone between the natural tooth on the other side and the natural counterpart root on the other side. So lesser diameter is favorable here. So you're planning in for hemisection, a lesser diameter implant, but at the same time, the root which you're considering here is a distal root. So there will, if at all you consider a distal root, replacing with a lesser diameter implant, then you have to expect some amount of jumping space here. Jumping space is expected. That means a space between the socket wall and the implant. The potential dead space that has to be augmented by bone substitute. And here again, the apical area is not going to be supportive in giving you enough primary stability. So length has to be more, because since you're planning in for a lesser diameter implant, primary stability will be lesser compared to the socket size. Apical area is not favorable for a primary stability since it's having a lesion there. And you need to consider a longer implant to derive more support from the still apical area. And now this particular tooth is having a kind of an infection. You can consider it as a chronic infection. It's having a chronic infection present there since a long time, present for a longer time. So bone loss is expected here. More than that, an infectious source like a periapical granuloma or even an abscess directly could be present in the apical region. Can we go in for an implant placement in a site having acute infection? Yeah, article says yes. Even analysis and systematic analysis says yes. But always an acute infectious site has to be managed with additional things, not just a direct implant placement. We need to make sure that that pus collection in that region will not make your implant having some kind of a hindrance for a future osseous integration. So a complete drain, even if it's an acute infection, a complete drain, enough of saline irrigation, making it absolutely clean, then you can graft that area and get your work done. What about chronic infection? Chronic infection means a long-standing infection having a granuloma or granulation tissue with good amount of bone loss in that region. There things becomes more tougher actually. It's a bone loss since a long time. That could have developed into a periodontal pocket area wherein you can insert the probe from the sulcus area. It might go into the furcation area or to the apical area, and it is present there since a long time. So it's a chronic infection. So a chronic infection means it's tougher to deal with than an acute infection. Acute infection has got a potential regenerative potential there. Chronic infection would have lost its potential. So you need to do everything possible to clear that area from granulation tissue and everything. And the grafting should have an augmentation with growth factors, not just a dry bone graft in that region. Try with something like a growth factor addition. So you can go in for a PRF mixed with bone graft or your sticky bone with an APRF membrane, which will be very useful in this case, because you're going to place an implant with a jumping space which need bone grafting. So you can give an additional support with a membrane over it, a barrier membrane over it, which contains growth factors. That is your APRF membrane. So that will be more ideal in this case. So your idea will be to go in for a hemisection, place an immediate implant with sufficient primary stability, graft that area with, if possible, going for your sticky bone. So that itself has got some amount of bone graft present in it. So it is bone graft mixed with bone growth factors plus a barrier membrane, which is biologic, not the collagen barrier membrane, which will come into contact with the nearby two surfaces of nearby two teeth. So we need to take care of completely covering it, which will be an additional burden for you. If you have a natural barrier membrane, that is your APRF gel-based barrier membrane, you can have a little bit of exposure of it as well. It stays there for a week together. So even it takes up to a month for a complete resorption. So that is also a favorable side of a barrier membrane, natural barrier membrane like PRF. So that also can be tried here, or rather you should be trying that as well. Okay, so let's come to that IUPA in designing it. So you went in for an RCT. RCT, you retained the mesial roots. Yeah, can we see that? Yeah, after observation. Yeah, that's how the condition is right now. So you have obturated two mesial roots wide apart. So you can have that is another favorable thing. You have got two roots here, two roots sharing the support. So that mesial side crown, when you see the crown of that mesial side, there is the retained crown on the mesial side, less on the distal side, which you are going to remove anyway. If it was other way around, imagine if it was the other way around, where you have a root or where you're planning to retain the root doesn't have enough crown, then you'd have been in trouble. This portion which you're planning to remove doesn't have much of a crown over it. The portion which you're planning to retain has got crown and root as well. So that is an ideal premolar. Can call it an ideal premolar with two roots. Yeah. What about the distal portion now? How have you planned it? Yeah. That's how it is now. How did you plan it? This planning you'd have done it prior to it. Okay, fine, you've done it. So how much is the crustal bone area, socket area, that is from the crustal bone of interradicular area to the interdental bone of the other area, the whole length of the span of the implant area. Available bone area is how much? 6 point? Let's call it 6. So you have got around 6 millimeter between the two, supposed to be two teeth. Between a premolar, the future premolar I'm talking about, between the section premolar or the molar which is going to be a premolar now, and the other molar, you have got around 6 millimeter. Within 6 millimeter, how much will be your dead space? How much space you have to spare in between these two teeth? 1.5 on both sides. So that makes it 3. Your implant size is how much? Whatever you have. It's 3.3. So that area is barely a permitted one. 3 millimeters makes 3.3. So if you place a 3.3 implant exactly in the center area, you are expected to have some amount of interdental bone and the implant tooth bone. You will have around 1.5 on one side and 1 millimeter on the other side. So if that 1 millimeter has to be kept closer, which one will you keep it more closer to which area? To the present sectioned area or to the nearby tooth area? Hmm? Which one will you have? You're going to connect these two teeth. I mean, these two portions you're going to connect. The other one you're not going to connect it. You understand? So the portion which you're going to connect would require lesser amount of lab area or prosthesis site, prosthesis material than compared to the other one, connecting both the teeth. So that means if you're having a millimeter of an area spared for metal and a millimeter of area spared for ceramic in the prosthesis side of it, you can make it a fully metal crown, a full metal crown, which wouldn't require that much of a space compared to a metal ceramic crown. For a metal ceramic crown, you would definitely require 1 millimeter space for metal and another millimeter space for ceramic. To make it full metal, you would require still lesser area in between the tooth and in between two teeth. I'll repeat it. A space of 2 millimeters is required. A space of 2 millimeters is required for a metal ceramic crown. If you make it fully metal, then slightly less is required. So leave how space more between the tooth and the implant site or the implant and the nearby tooth which you're going to connect. Which one will you? Which area will you have? Will you prefer to have a lesser space? If you need to spare 0.5 millimeters, which area will you spare? The one next to the tooth which you are not going to connect, or to the portion which you are going to connect? That requires lesser. So leave more space between the nearby tooth and the implant than the area which you are going to connect with each other. There you can do some kind of an adjustment, also adjustment. So not to leave much between space between the tooth which you are going to connect and the implant and the nearby implant than the area which you are not going to connect. So spare more space between the implant and the tooth which you are not going to connect. In other words, spare much space between 7 and 6 rather than the portions of 6 which you are going to connect together. You understand? Whether you have to connect it or leave it as two crown, we'll decide on it later. But spare, if at all you have to connect it, then it has to be closer with the nearby portion you're going to connect than with the tooth which you are not going to connect at all. There you would require some amount of a thickness. Understood? So here what we are planning to do is you're going to place an implant of 3 millimeter, 3.3 millimeter diameter in an area having a span of 6 millimeters. So it has to be exactly in the center. It has to go exactly in the center downwards, cross the infected site of the apex and get fixed to a portion still apically. So how much is the root length now? Yeah, from the interradicular area, it is 7.2. Take it as 7. Take it as 7. So from the interradicular area, it is 7. Can you consider this whole 7 or is it still 1 millimeter apical to it? No, I think you have got enough of bone on its distal side. So you can even have a flushing with the interdental area. That means that area has got lesser chance for resorption when you have one higher area on the distal portion of that particular implant. Distal portion of that implant will have a higher bone area. So that's going to be subcrustal considering 6 and 7 region, but equicrustal to the interradicular area. So 7 is okay. So 7, then millimeter, you will start getting some amount of resistance from the apical area, but there is an infection in that region that has to be considered. So how much millimeters apical to the root end? Another 7 millimeters. So we got around 14 millimeters of available bone height. Available bone height is 14 millimeters. So you can take the wall of 14 millimeters if you're going to go and get hit to the coronal or to the roof of the inferior anular canal. You don't want to do it. Go 2 millimeter. Yeah, spare 2 millimeters of that space. So that makes it 12. You don't have the size of 12, you've got 11.5. So 11.5 should be the maximum length from the interradicular area or the furcation, the crust of the bone in the crust. Right? So you need to take every care to not to go closer to 7. It has to be in the area of Yeah, the furcation area, it should be closer to the crest of the furcation. Closer to the crest of the furcation. That means you're going to place it in an area not following exactly the apex of this region. It should be more closer towards the interradicular area, interradicular bone, straight down up till the interradicular bone crest. Maximum permitted is 12. Your implant is of only 11.5. So 3.3 into 11 has to be fitted here, closer to the nearby component of the same tooth, sparing how much ever you can spare it between the distal tooth and this particular thing, so that you will never hamper the interradicular bone of 7 and 6. And you have to connect the 6 to the 6 and the both component of the 6. Reason, there is no interdental bone much to spare. So you have to connect it. You cannot have two separate crowns, because for that we need to have at least 2 millimeters between this tooth and the nearby implant, which you're having it less here. So since you are planning to connect it, that much of a 0.5 millimeter spared here. So your final implant will look closer to the mesial root of this particular tooth, long enough to have primary stability, sparing bone between the implant and the distal 7. Okay, flushing with the interradicular bone area. Okay, then grafting it with your bone grafting, whether it's going to be a PRF mixed with bone graft or a sticky bone, whatever it is, we'll see that. We'll see after opening that area and seeing how the condition of the bone is. Then placing a membrane over it will definitely help in some amount of an augmentation. Because this tooth is having acute infection, slight mobility is present there. So this area had a periodontal abscess, which would have taken away much of bone as well. So bone augmentation is also necessary here. So all considering all those things, section it, remove it, see the bone, evaluate it. So we can open it and see it. Anyway, you have to open that area. So sulcular incision of 7, and 6. Open that area, see for yourself, section it, take it out, section that particular area in such a way that you will not have any projections of that fragment of tooth is whatever is retained. You should not have a projection of interradicular area of the crown. Do you understand what I mean to say? Yeah, that interradicular area, furcation area, should be clean and clear for the interradicular bone to become interdental bone in future. If you happen to have any projections of furcation over the interradicular bone, you will not get a good healing. So open a flap, make sure that this tooth is made into a complete premolar without any additional projection in the interradicular area, over the interradicular area or in the furcation area of the tooth. Sectioned in such a way that will be completely restricted to that premolar size, not any projection into the furcation area. Make it clean, then evaluate the bone, decide on the final size. You should have a good idea, fair idea on how the jumping space is going to be, how much of bone is to be augmented. Accordingly, you make a decision on using bone graft and PR and barrier member. Okay.